So, pseudoexfoliation syndrome. Both these images are taken from the textbook Kansky 9th edition. So, pseudoexfoliation syndrome is an important ocular disorder which is characterized by deposition of dandruff-like fibrillary material over the eyes. It was later found out that this similar material is also deposited over skin and viscera like the heart, blood vessels, and other structures, and hence it was found out that pseudoexfoliation syndrome is actually a multifactorial systemic disorder. So, the exact cause of the disease is still unknown, and it is associated with systemic symptoms like there's cerebrovascular disease, there's low grade inflammation, there's hearing loss, and then there is elevated homocysteine level. So, the epidemiology goes like it's more common in females, it's more common in rural settings, it's more common in Scandinavian countries and Greece, but it is also seen worldwide, more commonly seen in the Scandinavian countries. Its incidence increases with increase in age, and it's more common in rural parts of the world. Also in India, in comparison to North India, South India has more higher prevalence of pseudoexfoliation syndrome. So the risk factors are there's increase in age, increase in distance from the equator, which leads to more sunlight exposure, more UV exposure. So these are the cases, and this pseudoexfoliation leads to around 30% cases of primary open angle glaucoma are associated with pseudoexfoliation syndrome, which is and as a complication of pseudoexfoliation syndrome, we have secondary open angle glaucoma, but that doesn't mean it's free of angle closure. There is a component of angle closure present as well. So the pathogenesis is it's a multifactorial disease. There is a deficiency in the matrix metalloproteases. There's increase in activity of this matrix metalloproteases, and then there's decrease in the activity of these endogenous inhibitors, which leads to excess oxidative stress, and altered this increased oxidative stress leads to accumulation of the dandruff-like material. So certain genes are responsible for this. One of them is CANCA1, the other one is LOX gene. So this LOX1 gene is more important, which is lysyl oxidase gene present on chromosome 15, and we've already spoken about how it's related to increased with increased homocysteine level. So what are the clinical features is it leads to mostly the disease begins as unilateral disease, and then later on within some time almost 50%, like 14% cases are converted to bilateral, out of which 6% of all patients with pseudoexfoliation will develop glaucoma. And it is found out that most patients had a baseline like they had ocular hypertension as a baseline finding, and mortality rate also is slightly higher compared to normal person because they also have these other systemic manifestations. So clinical diagnosis is very simple. We look at the cornea, we have Krakenberg spindle like deposit of this material, and endothelial defects can be there. This is why when operating for cataract surgery, it's always better to do a pre-operative specular microscopy. Then coming to the anterior chamber, so in the anterior chamber there is mild aqueous flare. So what happens is it alters the biochemical property. There's increase in protein in the blood aqueous barrier. Also there is alteration of the blood aqueous barrier. So this is also one of the causes leading to increased incidence of cataract. Then in the iris, so there are transillumination defects. Then there's loss of the pupillary rough margin, which can be seen in the first picture. And so basically this poorly dilating pupil. Then when we talk about the lens, now in the lens there are three zones. So the both picture B and C are depicting the same. So we have the central zone of pigment of the pseudoexfoliation material deposit, which is seen when the pupil is constricted. Then we have a clear zone, and then we have peripheral one more marking. So the peripheral mark of pigmentation is seen only when the pupil is dilated. Central clear zone is because of aberration with the iris, basically apposition with the iris. Then coming to the angle, and also cataract is again associated because of decreased level of ascorbate. Other than that, there is zonal instability leading to dislocations and subluxations. Coming to the anterior chamber, in anterior chamber there is trabecular membrane. In the trabecular meshwork, there will be pigmentation. So that is the Sampolesi line, but it is not a pathognomic feature. present, then this leads to basically open angle glaucoma. IOP is raised because of all of this. We've already covered the point how at a baseline level only is associated with ocular hypertension, and as we know, ocular hypertension is only treated when it is either associated with a thin cornea or there's increased cup disc ratio. But any patient with ocular hypertension who has pseudoexfoliation syndrome must and should be treated. Also, the pseudoexfoliation syndrome is found to be associated with thin corneas and a low BMI as well. So the presentation is of an old man. Actually, they say female is more common than men. So it's of an old person who's thin with the following complaints. So prognosis is worse. Basically, treatment, like the medical treatment, main problem that it is causing is cataract, and then there's glaucoma, mainly these two complaints. So for the glaucoma, but despite us treating with medical management, there is not good response. So we'll have to go for surgical management in the form of peripheral iridotomy, laser iridotomy, or trabeculectomy. So the problem with trab is that there's increased risk of infection and inflammation, hence topical steroids always need to be added. And the mechanism of glaucoma here is also called as capsular glaucoma. The mechanism would be that there's increased outflow resistance, which could be either because of mechanical or degenerative pigment, because of the presence of pigments present. So then we have other angle-based procedures like trabecular aspiration, or we can have ab internos trabeculotomy, wherein we ablate the trabecular meshwork. Then we also have these implants, express implants or tube implants. Then talking about the cataract surgery, but the next complaint would be cataract. So for cataract surgery, in fact, just doing phacoemulsification would help so much in getting rid of the pseudoexfoliation syndrome and controlling the IOP. So the complications with this is that we can have corneal endothelopathy, then we can have pore mydriasis. So this pore mydriasis can be tackled either with using a lot of viscoelastics or the push and pull technique, Coogan's hook, we can use iris hook, that Coogan's hook ke saath we can do this mechanical stretch pupilloplasty, then bolus pupil dilator. So all these things can be done. Other than that, there's zonular instability and there's increased risk of dislocation or subluxation of lens, either operate intra or late post-op also, and this can happen. So to control this, we use something called the capsular tension ring. So it has two purposes. During when we are operating, it is supporting, as well as the other cause would be that during later on also it is preventing the subluxation of lens. So its size is basically, that is the diameter is basically larger than the capsular bag, and it helps by expanding the capsular bag, equally supporting the capsular bag. It is recreating the capsule, and by doing all of this, it is preventing the incidence of posterior capsular rupture, pacification, and capsular phimosis. And there's always raised IOP, vitreous loss are also complications associated with cataract surgery. So they need to be tackled. For increased inflammation, we always go for use of topical steroids, must and should be added. So this has to be differentiated from true exfoliation. It is true exfoliation of the capsule seen with glass blowers disease following exposure to chronic infrared radiation. So very short and sweet topic. Thank you.